All right, so what if you could diagnose the majority of your dizzy patients before you even lay a hand on them for a physical exam? Well, in vestibular medicine, that's not just possible, it's expected. Your most powerful tool by far is a systematic history. So, in this explainer, we're going to break down the two foundational frameworks that let you turn a patient's story into a really precise diagnosis.
So, here's our game plan. First, we're going to talk about why the history is so central, why we call it the core diagnostic. Then, we'll dive into the Bárány categories. Think of that as sorting out the symptoms. After that, we'll tackle the TiTrATE framework, which is all about timing. And then the fun part, we'll see how they click together to build a diagnosis and how you can put it all into practice.
Now this quote, this really gets to the heart of it. It's a fundamental shift in how we think. The patient's history? It's not just a warm-up act before the real work begins. Nope. When you ask the right questions in a structured way, their story is the core diagnostic work. It's the #1 piece of evidence you're going to get.
And hey, this isn't just a nice theory. The data totally backs it up. Get this, studies show that a structured history can nail down the vestibular diagnosis in 80% of cases. Just let that sink in for a second. That's before you've even touched the patient or ordered a single scan. It just goes to show you the incredible power of a methodical approach.
Okay, so where do we begin? We start with the Bárány classification. Now, you can think of this as creating a shared, super precise vocabulary for us all to use. So here's a question for you. Next time you see a patient, can you categorize their symptoms into one of 4 key types right there on the spot? Well, this framework is exactly what gives you that power.
You know, what's so powerful about this is that it gives us these really precise definitions. It helps us move beyond those vague things patients sometimes say. So first up, you've got vestibular vertigo. That's a false sense of motion, like spinning. Then there's dizziness. That's that feeling of being disoriented in space but without any sense of motion. Third, we have vestibulovisual symptoms, things like oscillopsia, where the world seems to bounce around. That often points to a problem with the vestibulo-ocular reflex, the VOR. And last, we've got vestibular postural symptoms, basically unsteadiness or falls, which tells you there's a loss of balance.
Okay, so once you've figured out the what, you've got to define the how. Is the symptom spontaneous, just happening out of the blue? Because that starts pointing you towards things like Meniere's disease or even a TIA. Or is it triggered, say, by a simple change in head position? Boom! Your mind immediately goes to BPPV, benign paroxysmal positional vertigo. See? That one distinction carries a ton of diagnostic weight.
And here's the practical payoff. This isn't just some academic exercise. By asking 4 simple questions in the first 2 minutes, like, are you spinning? Are you feeling off balance? Is your vision jumping around? Are you actually falling? You are already building a really solid hypothesis about what's going on. It's just incredibly efficient.
All right, so we've defined the symptom type. Now what? The next step is to put that info to work, and that is where our second framework, TiTrATE, comes into play. You can think of this as the system that takes all those symptom descriptions and starts organizing them into a clear, coherent syndrome.
The acronym itself is actually your guide. TiTrATE stands for timing, triggers, and then a targeted exam. Now for what we're doing here with history taking, we're really going to focus on those first parts, the timing, the triggers, the duration, and any associated features. It's just a beautifully logical template to structure your questions.
So the very first move you make with TiTrATE is to classify the timing. Is this an acute vestibular syndrome? A single non-stop event that lasts for hours or even days? Or is it an episodic vestibular syndrome where you have these distinct attacks with totally symptom-free times in between? Or finally, is it a chronic vestibular syndrome, something that's been going on for weeks or months? Getting this initial sort right is absolutely fundamental.
Next, we're going to get really granular with the triggers. TPIAT treaty actually defines 6 specific types. So is it positional, like we see in BPPV? Is it brought on by head motion, which might suggest poor compensation? Or maybe it's visual motion, like scrolling on a phone, which is a classic feature of PPPD or persistent postural perceptual dizziness. Pinpointing that exact trigger really narrows down your list of possibilities.
Okay, now take a look at this because this is huge. The duration of an episode is often the single most powerful clue in the entire history. An attack that lasts just seconds, that screams BPV. If it's minutes to hours, we start thinking about things like Meniere's or vestibular migraine. But if it's continuous for days, well, that's an acute vestibular syndrome, and that could be a red flag for something serious like a stroke. This mapping is just clinically invaluable.
So, here we are. We've got our 2 powerful frameworks. Now it's time to put them together. This is where it all clicks. This is the synthesis step. It's how we go from just a list of symptoms to confidently placing the patient into a specific diagnostic bucket.
And this slide just lays it out perfectly. It's all about synergy. Bárány tells you what the symptom is, that's the phenotype. TiTrATE tells you how that symptom behaves, its timing and its triggers. So one defines the problem, and the other clusters it into a syndrome. They're two different tools, but they work together perfectly.
Okay, let's bring this all home. We're going to focus on the most critical, actionable points that you can start using in your practice like tomorrow. So, what are the big takeaways here? It's simple. First, you use Bárány to define the what, the symptom itself. Second, you use TiTrATE to define the how, clustering by timing and triggers. And don't forget, when you put these two tools together, you're going to get a solid diagnosis in 4 out of 5 patients just from their history alone.
Okay, so now that we've got these foundational frameworks down, where do we go next? Well, the next step is to do a deep dive into each of those TiTrATE syndromes. We're going to explore the specific clinical features for each one, and, this is critical, how to use red flags to guide your next steps. You're not going to want to miss part 2.
Hey, thanks so much for joining us for this breakdown. If you want more in-depth resources on all things dizziness, vertigo, and imbalance for both you and your patients, head on over to AustralianDizzinessClinics.com. And hey, if you found this useful, we'd really appreciate it if you'd subscribe and maybe leave us a rating. Thanks again.